On behalf of the American Heart Association, I would like to welcome you to our final session of today's Pain Management Summit, Disparities in Pain, Promoting Health Equity Through Multimodal Pain Management. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. Throughout this panel discussion, you will have the opportunity to submit text questions for our panelists using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A as time allows. This panel discussion will be recorded and available within the coming weeks at heart.org/pain management. It is my pleasure to introduce our moderator for today's panel, Dr. Wairee Oruru. Dr. Oruru is an interventional pain physician at University of Pittsburgh Medical Center in Williamsport, Pennsylvania. He completed his medical training at Mayo Medical School and his residencies at Brigham and Women's Hospital for general surgery and Beth Israel Deaconess Medical Center for anesthesiology. He subsequently completed his chronic pain fellowship at Massachusetts General Hospital. Dr. Oruru also has a master's in public health from Harvard University School of Public Health. He has published over 140 peer-reviewed articles, as well as multiple book chapters in the field of anesthesiology and chronic pain management. Thank you for moderating today's panel, Dr. Oruru. I'll turn it over to you to introduce your panel and begin today's discussion.
Great. Thank you so much for the kind introduction, Christine. I'm sincerely excited to discuss such an important topic that we have with such an esteemed panelist. And I'm just beyond words in terms of just sharing how much knowledge we have here on this podium together. And I really got to say thank you so much to the American Heart Association for bringing every single one of us together in this platform to impact lives of patients that are in chronic pain. With no further ado, I would love to introduce the wonderful speakers we have today from Dr. Doshi, Dr. Guri, and Dr. Mariano. It is truly a pleasure and an honor to have such a wonderful, esteemed group of people who they're taking the time from taking this out of their personal time to really share their knowledge with us. I will start with Dr. Doshi. So Dr. Tina Doshi is an assistant professor in the Department of Anesthesiology and Critical Care Medicine, Division of Pain Medicine at Johns Hopkins University. She is a director of inpatient chronic pain services and a director of pain education. She does hold a master's in clinical investigation from the Johns Hopkins School of Public Health with a postmaster's certificate in sequence analysis and genomics. And she is just such a wonderful friend. And I have to tell you this, that in addition to her clinical work as a pain physician, she's been involved in multiple clinical trials for the treatment of chronic pain conditions. Her interest varies from craniofacial pain, developing precision medicine, and all of this geared towards an approach for pain treatment for patients that have chronic pain. You know, her work has been supported by amazing institutions such as the NIH, the National Institute of Health, Doris Duke Charitable Foundation, and the Foundation for Anesthesia Education and Research. Dr. Doshi, thank you so much for joining us. The next panelist we have on here with us is Dr. Jonathan Guri, who is an associate professor of anesthesiology at the University of Arkansas for Medical Sciences. He is also the director of Chronic Pain Division and also the program director of the Pain Medicine Fellowship there at University of Arkansas. He's a chief of staff elect, as well as an associate chief medical officer at the University of Arkansas. Dr. Guri is exceptional and such a pioneer in the field of pain medicine. He did complete his medical school and residency at Cornell School of Medicine, and he also completed his pain fellowship at Emory University in Atlanta prior to joining the faculty at University of Arkansas of Medical Science. Dr. Guri is a high-quality physician in the pain space, a key opinion leader, and he really focuses on improving function through opioid sparing in his interventional pain practice. His research is vast and includes racial disparities in chronic pain care, novel neuromodulation indication, and also implementation science as it pertains to really taking care of patients with disparities across the chronic pain space. Dr. Guri, it is truly a pleasure having you to join us today, and I'm looking forward to such a fruitful conversation. The next panelist we have is Dr. Edward Mariano. Dr. Edward Mariano is truly a legend in our space. He's a professor and senior vice chair in the Department of Anesthesiology, Perioperative, and Pain Medicine at Stanford University School of Medicine. He is also the chief of anesthesiology and perioperative care service at the Veteran Affairs Palo Alto Healthcare System in California. He has developed techniques and patient care pathways to improve postoperative pain control, patient safety, and other outcomes. And what's just amazing about Dr. Mariano is he's educated his peers in the field of anesthesiology and pain with vast majority of over 250 peer-reviewed articles that are indexed in PubMed. He is a president of the California Society of Anesthesiologists from 2022 to 2023 and has held leadership positions in numerous societies such as the American Society of Anesthesiologists, American Society of Regional Anesthesia and Pain Medicine, and multiple journal editorial boards. What is really outstanding about Dr. Mariano is he not only mentors beyond measure, but he's a recipient of the Veterans Health Administration's John D. Case Award for Physician Executive Excellence and has worked on key national healthcare initiatives in the U.S., including accreditation of regional anesthesiology and acute pain medicine fellowships, pain management guidelines, development of quality and cost measures in perioperative care, and the National Academy of Medicine Action Collaborative countering the United States opioid pandemic. Without no further ado, Dr. Mariano, thank you so much for joining us. And again, looking forward to all the fantastic and wonderful contributions from you as well. So, without delaying any other part of this conversation, it's truly exciting because part of what has been a huge issue just in medicine overall is the idea of disparities. You know, our goal today is we're going to focus on disparities in pain management. And hopefully we can get to talk about ways that we can promote health equity through this multimodal pain management approach that could be offered to every patient we encounter who could be in chronic pain. So Dr. Doshi, if you don't mind, we're going to get started with you. In your experience overall from Hopkins to just a career you've built in pain management, can you share with us some of the difficulties and challenges you've seen in patients who suffer from chronic pain in an inpatient setting?
Yeah, definitely. The inpatient setting is a very different context from which we typically see patients, because a lot of us are used to seeing patients in the chronic pain clinic, but it's in the inpatient setting that we kind of see a different sort of, they're in a different environment. And oftentimes these patients are not being hospitalized for pain, and pain is not the primary concern. And so the pain aspect of their experience is often overlooked as the medical team tries to balance all these other issues, tries to address all those things. And it's often not until the patient's getting ready for discharge that we realize, oh, well, there's still this unaddressed issue of pain, or they're on a pain regimen now that we kind of put them on. And it's not appropriate for discharge. And it's almost like an afterthought as we're juggling all these other inpatient things. And this problem of pain then can keep the patient in the hospital for longer than we originally intended, because even though the original issue is addressed, they still have the unresolved issue of pain. And I get it, it's hard, when a patient is in the hospital, you're managing so many different things, and it's easy to put pain lower down on the priority list. And sometimes the things that we use for pain control can make the other inpatient problems harder to manage. Things like mental status or hyper or hypotension or chronic kidney disease. And those are all the other factors that we have to consider. But on the flip side, what that does is it makes the patient feel like their pain experience is being minimized. And for patients who suffer from chronic pain to begin with, that can make it even worse for them, because a lot of times those chronic pain patients already come in feeling like their pain is minimized. And then it can make patients feel like, or it can make the clinicians feel like patients are just being difficult. Like, you're not focusing on the right problem here. You're talking about your pain, but what I really want to do is manage your hypotension, that. And so those that interplay makes it really difficult to manage, particularly this issue of pain in the inpatient setting.
Well, that's such a wonderful, wonderful thought. It takes me back to just the idea of thinking about that ideal inpatient individual who could be a loved one or anyone, and how it's so hard to divert from that primary concern, which could, for example, be management of COPD, and the distraction away from issues like the chronic pain state, and how that can even impact chest pain, and just seeing how that's been such a complex setting that makes it very challenging for providers to decipher. Now, great thoughts. The one thing I was going to also put out there to you, Dr. Doshi, is now, in addition to those challenges you've mentioned, when you start thinking about, racial distribution or disparities that happen in medicine, and how this factor can even compound managing patients in an inpatient setting who could be suffering from chronic pain, how have you had to manage or deal with those scenarios, and is it something you encounter often, or have you had colleagues that have encountered it, or you've discussed it in meetings? I'm really curious to hear your thoughts on that.
So can you clarify the question, like how manage disparities, or how manage the difficulties in the interplay between the other medical issues and the pain?
That's right. So the challenges and interplay with disparities, as it pertains to whether it's socioeconomic or whether it's racial, or even if it's a medical, because disparities can also be from just a lack of understanding. Disparities can also be from a lack of understanding of the medical condition itself. So just more along the line of how you've managed it in any way, shape, or form, or even if you've encountered it. And it doesn't have to be from the socioeconomic or racial, but even from a medical component as well.
Yeah, I think a lot of it comes down to really understanding the individual patient and their context, what is going on with them in their lives beyond, yes, they're here in the hospital, here's their hospital problem, but okay, what is their pain experience? What's their pain background? And what have they tried in the past? What's their experience been? And then understanding their values, okay, is their goal to just get out of here from the hospital as soon as they can? Or is it to really try to address all the possible issues while they're here, and so it really helps to frame your thinking around the patient and their individual values. And then that helps guide you into bringing in all the different members of the team and saying here, let's have a discussion about what this patient's goals are, what our goals are, and make sure that those align. And a lot of times it just comes down to spending time with the patient. This is really hard in the inpatient setting, right? We're all busy all the time, and we're overloaded, and hospitals are always full these days, but there's a lot to be said for just sitting down and taking that extra 15 minutes. Hey, how are you feeling about this? What can we do to help you feel better? And it's worth listening to the answer to that question.
So what I hear you say, Dr. Doshi, is there is power in listening, no matter the condition, no matter the complexity of the challenge in front of you. And in the end, every patient has a value. in the world. Every patient can be valued based on the challenges they want to communicate, and whether it's socioeconomic, whether it's from the the diversity of medical complexity, just listening to the patient is so important. And that is truly powerful. And now Dr. Guri, we're going to jump a little bit to you for a little bit. How often do you notice there is a patient's race and that a patient's race and socioeconomic status can actually impact pain management care that they receive in a hospital setting? How often do you notice it?
Yeah, thank you for that question. And first, I would be completely remiss to not say that this is such an honor to be on a panel with the four of you or the three of you. I mean, this is absolutely amazing. Back to the question, how often do I notice it? Unfortunately, daily, if not hourly. It's something I've experienced myself. It's something I've seen my family experience, my children, my grandparents, my parents. And the way I would break it down is, I think there's really 3 steps that are needed for someone to get to having pain, to having their pain treated. First, there has to be belief, then there has to be empathy, and then the provider has to give them access. So as we break those down, the belief piece. So, all of us have seen that study out of Hopkins Medical School about, things that medical providers believed about different patients of different races, right? And we've all treated patients where they've said that they've had some symptom, and to be frank, we didn't believe it, right? The one thing that differentiates pain, and especially chronic pain, which is often due to neural inflammation and not really a structural issue causing pain, is there's oftentimes not an objective finding that we can hang our hat on. It's all subjective, right? So belief is paramount. If you don't believe the person, then there's no X-ray, there's no EKG, there's no cath, there's no echo, there's no MRI that you can do to allow you to change your belief. It's literally me listening, as Dr. Doshi said, and then me translating that into action. And so for a lot of patients of different races, of different genders, socioeconomic classes, sexual orientations, we had a baseline, just don't believe them. And so then full stop, they're not getting pain care. But even if we believe them, we have to empathize with their situation. And so my son was running around my house last week. He fell, he skinned his knee, and then he came to me crying. I believed that he was in pain. I didn't have a lot of empathy because I told him to stop running, right? And I didn't really think that his pain needed to be treated. So, I put a Band-Aid on it. I kind of rubbed some dirt on it. Really, I didn't. I rubbed soap on it, but that's a different conversation. But I didn't treat his pain. I didn't give him Tylenol. I didn't give him opioids because I don't know if the empathy was there. And so a lot of times we empathize with people who we're familiar with. If we see a patient that looks like our daughter or our mother or our father, we're probably going to have a lot more empathy than we are with patients who we aren't familiar with. And if we aren't familiar with other groups of people, large groups of people, then we may not have the empathy that's there. And it's been shown when you don't have empathy and familiarity, then it's going to decrease your quality of care, and physician talk time goes up, patient talk time goes down, and we don't care for the patient at the same level. And the last piece is the access piece. Just because we believe someone and we believe their pain should be treated, we then have to make sure that they have access to the treatment they need, right? And fortunately or unfortunately, we're the gatekeeper. And there are times when we think someone is in pain and we believe they should be treated, but either due to insurance issues, due to where they live, due to our skill set or our comfort level, we may not be able to provide the patient with what they need. And so I think it's unfortunate because it's not only a problem that patients aren't getting the pain care they need due to factors out of their control. But there's so many places along the chain where that kind of what I would call social contract that we have with patients, that they come to us with their, when they're in their most need, and we provide care, where that social contract can be broken.
Wow, that is truly a powerful message. It's like hearing Dr. Doshi say, you just got to listen. And then Dr. Guri expands on that and say, you listen, but you have to show empathy. And the idea that one has to understand and encounter what it means to listen and encounter what it means to show empathy. Dr. Guri, just you joining those 2 points together is so powerful. Then you add a layer of it, of familiarity. Not only identifying it, is being familiar with people you need to show empathy to impacts how you think about listening and showing empathy. Incredible. You really took me to an inpatient ward when I was taking care of a cardiac patient who actually had post-thoracotomy pain, and wow, it really is a powerful message. Thank you, Dr. Guri. I was going to extend, I just add a little bit more curiosity to this conversation here. Dr. Guri, when you think about some of these variables and factors like empathy or listening critically, and again, it could be either patient-related or hospital-related, what do you notice as a common contributing factor to some of the stigma or the reason that we see as it pertains to showing empathy, listening, or other variables as it relates to pain management? Like, what are some of these factors that you would say you've observed that could be a stigma?
Yeah, I think that's an outstanding question. And I would say there's so many that I'll try to boil it down to a couple that come to mind. One, especially when you have when you have patients who are in hospitals, and they're often there for, as Dr. Doshi said, other medical conditions, right? They're there for their heart conditions, they're there for strokes, they're there for different reasons. Oftentimes, our goals don't necessarily align with the patient's goals, right? Patients come to medicine because of pain. Patients don't come to the emergency room and say, I'm having a blockage in my left main. They come and say, I have chest pain. And patient's goal is oftentimes to get out of pain. Pain is the warning light for us that something is wrong with our body. And while we will take a patient and say, well, I understand you have pain right now, but as I'm going through your tests and I'm reading your labs and I'm going through your imaging, or I'm reading your EKG or looking at your cath, I see that there's an issue that needs to be fixed that I think is more important than your pain. And oftentimes when we fix that problem, we're probably addressing the patient's pain, but the patient doesn't know that. But honestly, that's not always true. And there's a lot of times when pain gets put on the back burner because we all know that pain is not going to kill you, right? Your heart will kill you, your lungs will kill you, issues with your brain will kill you, but pain in and of itself isn't going to kill you. And as physicians, oftentimes we think of our goal as to make sure that patients stay alive. But I would expand on that a big part of our goal is to make sure that patients have a really good quality of life, and hopefully a quality of life at the level that they had before they came in the hospital. We can't always accomplish that, but hopefully we can try. And pain is a big part of that. And patients really feel it when we disregard their main complaints. And so oftentimes that is one thing that we don't take the time. And I think that listening piece is a big part of that, of really finding out what are the patient's goals and finding a way to have a conversation where we either align our goals, we explain to the patients why our goals are more important because they're really a life or death situation, or we explain how our goals really are in alignment. And that little bit of expectation setting of saying, hey, I understand that I am not directly treating your pain, but indirectly through these treatments, your pain will get better, I think will fix some of the problems you just discussed.
Oh, wow, that's incredible. It's kind of like the lack of understanding of the challenge, is these are contributing factor that actually could make, or propagate some of the difficulties and the challenges that comes with disparities. So for example, not listening to the patient's complaint, or not listening to the reason why the patient's there, or not understanding where the patient's coming from, could magnify even how we provide care across the board. That's incredible, Dr. Gori. That's amazing. Dr. Mariano, we're going to switch over to you. And one of the things that we would like to just really discuss, just piggybacking on what Dr. Gori just mentioned, is, when you notice some of those challenges and biases among chronic pain patients, what are some of the strategies that either you've implemented or you've discussed from a scholarly perspective, or you've actually heard your colleagues utilize to mitigate some of those biases, so that we can eventually start leaning or moving towards improving patient outcomes who are in pain?
Yeah, I think, and thank you for the question. I also want to just say how excited I am to be on this panel, and I'm thrilled that the American Heart Association has taken on pain as an important topic, because I think it does affect so many aspects of health. If I look at the problem I think is of disparities in pain management, I think is incredibly broad. And I think because of that, it just seems incredibly intimidating for many of us, because how do you fix that? And I think there are individual factors. I think there are definitely structural factors. And I think that one of the messages, one of the lessons I've learned, I think, in my career so far, is that in order to really impact care, and I think that many of us, especially in academics, we have these careers in which you're focused on providing high quality care, you're teaching, you're doing research, and it's very humbling, I think, to recognize the fact that sometimes the research that we do that hopefully answers questions that will help patients get better care doesn't actually change care. I mean, it's incredibly humbling. And we have these discussions at meetings together, and we're all of same mind. This is the best way we should take care of patients. And you realize that when you talk to people, other clinicians, patients from different parts of the country, that is not what's happening in the real world. So how does that happen? I think that recognizing that what we think is good care is not always applied to everyone, I think is really an important first step. It's important acceptance before you can do something. And I think the ways to approach it, I think oftentimes we think of it as, well, we need to make sure that our individual clinicians aren't imposing their personal biases. But I think it's a bigger problem. It's interesting. There's a Dartmouth professor, he's non-medical, I think he's economics, named John Wenberg, and he describes his concept of unwarranted variation. And it's actually a friend of ours, Brian Seitz, who's the editor-in-chief of Regional Anesthesia and Pain Medicine, sent me his name and had me read some of his work. And it's interesting because the way he describes unwarranted variation is that it's the flip side of warranted variation. So warranted variation is individualization of care. It's good personalized medicine because you're influencing the way you take care of patients based on good evidence, based on patient preference, or based on patient condition. So you've adapted what you normally do so that way it is actually dealing with the patient in a way that is patient-centered. Now, unwarranted variation is the opposite. It's variation in care that has nothing to do with patient preference or patient condition or evidence. And that's really where I think sometimes we see this incursion of bias and structural racism and how it affects pain care. I think that the ways that we've tried to address that the latter aspect, this unwarranted variation, is to try to take what we know in terms of good evidence-based care and develop guidelines, at least guide practice. And I think that we've done a fairly good job of that in pain. But I would say that there's a lot of work to do because we don't always collaborate across multiple societies. There are many societies that represent pain medicine. And there have been some good collaborative projects, with the Multi-Society Pain Working Group. We've also seen in my specific area around perioperative pain, we've been able to coordinate the efforts from the American Medical Association, American Hospital Association, the American Society of Anesthesiologists. We've had American College of OBGYN and multiple surgical specialty societies that combine together 14 organizations in all to try to accept what we consider the good principles of acute pain medicine. I think establishing those as common language, I think, are really key because that actually helps us continue the conversation with health systems, with payers, with our regulators, as well as our legislators, because the last piece that I think is really important, especially with trying to provide some long-term solutions to disparities, is that it actually takes advocacy. And that's not something that I, as an academic physician, when I was early in my career, ever thought I would get interested in. But you realize that so much of medicine is dictated by the laws and regulations that affect care. And I think that we all know this because we live that life, and we have constant metrics that we have to follow, and we have hospital administrators that are keeping track of different things that we have in place. But sometimes we don't realize that as physicians, as healthcare professionals, we actually can be on the front end. We can support legislation like the No Pain Act that was actually passed at the end of 22, that actually helps provide increased coverage through CMS for non-opioid pain management. That's big for us. We'll see how this pans out in the regulations. We can also affect regulations because we can work with accrediting bodies as well as we can work with CMS and state-based agencies to try to make what we consider good pain management expected at hospitals. Because I think we know that while we oftentimes think about the highly visible differences between people and how that can influence bias and how it can influence disparities in care, I think we also know that there are a lot of overlapping issues like being underinsured and the location where you can have services in your hospital because you may not have coverage within your network to go to hospitals that have higher level of services. So while it's not explicitly race or other visible characteristics that make that determination, it is nested within a much larger and structural issue within our healthcare system. So I think that those are a lot of other things that we can work on. But I think we can start at least with agreeing with what good pain care looks like. And also, I think, recognize the fact that many of the decisions that we sometimes apply are not always couched in good evidence.
Wow, that is such a powerful response in terms of some of the solutions that one can think about as we think about disparities or just variation on how we practice. I love your concept with unwanted versus wanted. That is such a powerful summary, and it really highlights and summarizes the complexity of what we actually, as healthcare providers and even patients, can walk into in a hospital setting. And then thinking about the ideas that this has to be a collaborative approach. We need to come together and talk about it, decipher these challenges, come up with guidelines, whether it's multi-society coming together or whether it's at a regulatory level, implementing some of these guidelines. Dr. Moreno, that's such a powerful response. And I wish I could peel that onion a little bit more, but I know we have other questions to go through, but that's such a great response. Now, but just piggybacking on just what you've just said, one of the challenges, like you mentioned, is this is a very complex problem. And a lot of times we as providers and even as patients, it's very uncomfortable to voice or talk about it. And one of the things that has been and continues to be a problem is the healthcare setting is very stressful. And in the presence of stress, a lot of times we don't even notice our own biases. Now, from your experience, what tools have you utilized, or would you suggest that one can explore to recognize personal bias?
Yeah, so I think that first, I think it's important that we all recognize that we have biases. Everyone does. And I think that if when we think about the way that we try to identify the presence of implicit bias, there are multiple different tests, the assessments that you can do, and many of us have done them. Implicit bias assessment test. I mean, there's association tests where you can go through and at least recognize the fact that we all have them. I think that what's sometimes frustrating about those processes, because we've all done it. We've all had, and now more recently, many of us within our institutions have had these mandated to us in the form of online training. So we've all done these things. But now that you recognize that they exist, well, what do you do about it? And I think that that's probably the more frustrating thing for healthcare professionals. And if I continue some of the one line of thought that I had introduced before, I think one way that we can address bias, I think, is by trying to create much more evidence-based, evidence-guided patient care pathways and protocols. We can put together what good care looks like and make sure that patients with similar conditions are being approached in the same way. That doesn't mean that everyone gets the same care. And so don't misread what I'm saying by creating recipes. That's not what we want at all. But we do want evidence-based checklists to say, well, we have good evidence that these types of therapies in pain management make sense. And is there some reason why my patient is not a good candidate? And that's how you differentiate warranted from unwarranted variation. If you think, oh, well, maybe that doesn't really make sense for my patient, but I can't find a good evidence base for justifying that decision, then that may be bias, and maybe I'm thinking about it the wrong way. Other ways that I think have been effective, and actually Dr. Gori and Dr. Doshi and I had the pleasure of writing a paper together. So we're co-authors back a couple of years ago. It was led by one of our friends, Dr. Natalie Strand. And one of the things that we tried to look at was looking at the structure of pain medicine and how racism can really play a role. And we tried to take more of this inside out approach, going from individual to a much larger community to see are there things that we can do. And one thing that we can do within the individual, or at least within our local sphere, is to try to directly target the things that we recognize are related to bias. So bias and stereotypes are things that we all know them. We all have, we've all applied them at times. We've heard them used in jokes at times. I think that one exercise that can be useful is to take those recognized stereotypes and try to flip them 180 degrees. What if you're looking at a patient and you would normally tend towards one set of stereotypes, and you try to apply a stereotype for a totally different group? It helps, it forces you, because it's just so ridiculous. It helps you recognize the fact that all stereotypes are ridiculous. And I think that also helps pave the way, I think, for deconstructing some of those stereotypes we have about groups. I think the other thing we can do is really make people be individuals, to recognize the humanity of each person. So you may see differences between yourself and your patients, or you may see people and start to assume that certain groups based on their visible characteristics are different. But if you start to talk to people, and this really, I think, ties in what Dr. Gori was saying about empathy and what Dr. Doshi was saying about active listening, you may find, and you will find, that you have much more in common with people than you realize. Even if your skin is a different color, maybe English was not your first language. Maybe you're first generation and you both share the fact that your parents immigrated to the United States. Maybe you both grew up in rural communities, or small schools, or had a lot of siblings, or had no siblings. These are the kinds of things that I feel like connects us human to human, and helps really deconstruct a lot of these biases. And that's the end that I feel most passionately about. It's not the fact that we should detect whether or not we have biases. We already do. We know that. It's what do you do next? And I think that that's something that we can definitely teach, and it's not just for us as clinicians. I think that that's something we need to apply at all levels. It's the person that greets you when you enter the clinic, or enter the hospital. It's the person who takes you when you're lost, from place to place. And it's every single person that touches that patient in the course of care. I think they all have to have similar types of active exercises to try to combat bias.
As the more I listen to you speak, Dr. Mariano, the more I realize I'm going to have to go back and play this recording, because I do think there's the level of detail that comes with solving such a critical challenge, really goes back to the same thing our panelists have been talking about, from active listening, recognizing empathy, now taking the time to be aware that it's okay, you have bias and it's how your body works, but then it's really doing the next steps to recognize and being able to use the tools that is necessary to make sure you're converting those bias to actually doing good, no matter the setting you are. I got to say, Dr. Mariano, thank you. Mariano, thank you for taking the time to really explain some of those complexities. Now, the one thing that I was going to just switch gears to is the challenging population in pain management. Dr. Gori, if you don't mind, one of the things that I was going to get at with hopefully this panelists can talk about a little bit, and is that when we encounter a lot of these challenging patients, and it could be from just having multiple comorbidities in an inpatient setting, whether it's uncontrolled hypertension, uncontrolled diabetes, addiction, or just being in multiple diverse, poorly controlled chronic and acute pain states. Can you share how you've used a multidisciplinary approach to really address some of the issues that these challenging patients may have? And I really want to open this up a little bit more to the panelists to comment on this, because the idea of multidisciplinary challenge using a multidisciplinary solution varies from setting to setting. So I'm really curious to see how, how you've managed a scenario like this, Dr. Gori, and Dr. Doshi, Dr. Mariano, please feel free to chime in.
Yeah, no, this is a great question, and a challenge that we've all encountered. And I think it's important to discuss, because when we think about the development of chronic pain, one of the things that really increases the risk of developing chronic pain is poorly controlled acute pain. So if you leave neural inflammation over time, that neural inflammation will become basically permanent. And chronic pain is a lot harder to treat than acute pain. And so we have to be aggressive about treating acute pain. And then we have to be aggressive about, backing down some of those treatments once that pain is starting to decrease, once the body is starting to heal, so that patients don't have the unwarranted side effects of those treatments. And so when I think about kind of acute pain treatments, I think about opioids, I think about adjuvants, I think about regional anesthesia or procedural intervention, and I think about alternatives. And so when someone has acute pain, especially post-surgical pain or pain post-injury, I would say that opioids are still the mainstay. And I think that it's okay to use opioids in patients who are acutely injured or who are having acute pain. We just have to be mindful of treating that pain aggressively and then backing down on those opioids when those patients are getting better. And so, there is a study that out of our institution that shows that for every day that you increase a prescription that you send someone home with, you're also increasing their risk of being on opioids in a year or 3 years. And so you just have to be mindful of really providing a good risk-benefit analysis and helping patients understand that take opioids when you're in pain, but if you don't need them, don't take them, because that's when you get in trouble. Then if we're able to use interventions to block an area from having pain, then we should use them because those are going to minimize the need for opioids and make the opioids more effective. Then the challenge becomes adjuvants, because a lot of the adjuvants that we use often have side effects that can really be an issue when you have comorbidities like heart conditions, or if you have any kind of risk of dementia or delirium or somnolence. So we have to make sure that we're using adjuvants appropriately, but some patients can't have NSAIDs. Some patients can't have SNRIs. A lot of patients shouldn't have gabapentinoids. So we should be real mindful of what the side effects of all those are. And then the last one is the alternatives. And I would say that's just really good care. Kind of what both a lot of the things this panel's already discussed, but sometimes giving someone an extra pillow or giving someone ice or heat or helping them change positions or talking them through or letting them know that, hey, this thing I'm going to do is going to hurt, but it's going to get better tomorrow. Just setting expectations can really be helpful when it comes to this kind of global management of pain. And I would say the last piece as we talk about kind of the multidisciplinary care of pain, I think we have to, while we're in the hospital, we often have all the resources in the world to treat someone's pain, but eventually they're going to have to go home. And so we have to be mindful of what resources they are going to have access to when they leave the hospital, whether they're going to have someone with them who can help manage their medications, whether they're going to have someone with them who's going to be able to provide the level of care, that extra pillow, help them get ice, put that lidocaine patch on their back, all those things that they may not be able to do themselves. And also the socioeconomic piece, will they be able to afford those treatments that we're prescribing? The amount of patients who've been prescribed, going back to the cardiology world, prescribed a, anticoagulant medication that they can't afford is staggering. So we have to think about those same things when we think about pain medicine. And oftentimes that's when we bring in social workers or other kind of staff in the hospital to help us really understand how we can provide more resources to a patient so that they can get the care that they need once they leave us.
Wow, that's incredible. Any thoughts from Dr. Doshi, Dr. Mariano? Dr. Doshi has actually, it's kind of a nice segue because Dr. Gori did mention something that's really critical, and he talked about not just the inpatient setting, but the setting beyond the inpatient world, which is, what therapies can these patients even have access to beyond the inpatient setting? And it got me thinking about the whole idea of complementary care, and how one can think about an integrative method, to continue that care from the hospital beyond the hospital, and do you have thoughts about, how one can think about it? What are even some of the options for integrative care? I'm really curious your thoughts about that.
Yeah, no, I love this question. And I 100% agree with everything that Dr. Gori said. But I will emphasize one thing. Just because we need to be aggressive about pain care doesn't mean that the care has to be aggressive, right? And so there are lots of things that we can do for patients that are part of the tools in our toolkits. And to try to mitigate a lot of these disparities, we have to make sure that we're offering everything to everyone and thinking about, okay, some of these things might not be right for this patient, but we'd have to think about all those things, just like Dr. Mariano was saying, okay, what's the evidence basis and does this apply to my patient? And so that can range from everything as invasive as surgery or interventions to as benign as using like hot or cold packs, or teaching them deep breathing exercises, mindfulness, meditation. And the inpatient setting is a perfectly fine place to do these things. And these are interventions that the patient can learn, I can take home with me, like deep breathing and mindfulness. Mind-body therapies, there are a lot of them that can be self-guided. And the inpatient setting is a great way to introduce these ideas to patients who might never have heard of them otherwise. Like, hey, when we're thinking about managing your perioperative pain, and we know you're stressed out about this, we know that you get really anxious, and we know that your pain is going to be worse. Like, here are some mindfulness exercises that could be helpful for you. so that can be really useful. In terms of other integrative therapies, a lot of times it depends on the resources available at your particular institution. And so some will offer things like massage or acupuncture. And that's great if you have that resource available for the patient in the inpatient setting. But as Dr. Gore mentioned, you got to make sure that it's something that can be sustainable, even outside after they leave the hospital. And then the other thing I wanted to mention is this idea we had at Johns Hopkins, this idea of a comfort menu for patients. Like everybody, we had a list of items that people could request and ask for to make their stay more comfortable. And the really interesting thing is some of the most frequently requested items were moisturizer, lip balm, and pajama pants. And this makes a huge deal, right? I'd love to have pants when I'm, walking around the hospital. Of course, that makes total sense, but you don't think about it until you really understand the patient experience and think about, okay, what are different ways that we can make this patient have a better experience? And that's exactly what pain is, right? An unpleasant sensory experience. How can we make it a more pleasant experience?
Wow, that's really incredible. I think I'll lean more towards the pajamas if I'm hospitalized and you're caring for me, Dr. Doshi. It's really fascinating, right? Because you really got me thinking about how simple we also have to migrate our thought process as we think about bias, as we think about just the disparities that exist. Sometimes it boils down to some of this really simple thoughts of what would you offer a loved one when you're in a hospital. I really never thought about the whole idea of a comfort menu until you started going through the items. And I think for me, that's very, very powerful. Now, Dr. Moreno, I'll shift a little bit to you in terms of thinking about chronic pain patients as it pertains to thinking about the multimodal pharmacologic approaches that you would consider as an anesthesiologist for patients who have acute or maybe acute and chronic or even chronic pains in an inpatient setting. In adjunct to some of the things Dr. Doshi has mentioned, what are some of the things that you consider in your practice?
Yeah, so I think that there's a lot of overlap between acute and chronic pain in terms of multimodal management. I mean, I think while some of the therapies and interventions differ, the categories are very similar. I mean, I loved what Dr. Doshi was saying just about really providing that humanity. And I think that really makes a big difference. I think the recognition to the point where Dr. Corey was talking about how important it is to believe patients. I mean, I think, but even just from a practical standpoint, I mean, how we've all been in the hospital, we've all been there when patients are being told, oh, we need you to go and walk around and do, but I think the idea of covering their legs with pants instead of just having them trek around the hospital in their hospital gown is just, it blows your mind, right? You think why aren't we doing this for everyone? But I think that a point for me, especially with patients in chronic pain, I think more so than patients in acute pain, I think it's really important to think about some of the issues about access that have been brought up during this session. It's just, I think that it's very easy for us to say, well, everyone needs to have this, this, and this. How often have we in our academic centers talked to colleagues or maybe even generate ideas within our own groups about, oh, we're going to create this great app that patients are going to go home with. It's going to help basically be their virtual coach for pain management. And then your patients are either pay as you go, or they don't have a smartphone at all. So I think that whatever it is that we do in terms of providing that multimodal approach to pain management, it has to be applicable to everyone. It has to be accessible to everyone. You don't have to have an app for some of the mind-body therapies and deep breathing exercises, although they do exist. But it may be important to make sure you still have old school written instructions that patients can practice, when they're in the hospital, and something that they can go home with and refer to, because I think that that's really important, because once they're out of the hospital, and if they are already patients who live with chronic pain or may go on to develop chronic pain, they're going to want to have a process that they go through. Well, what happens? I'm getting an exacerbation of my chronic joint pain now. Well, this is what I was taught when I was in the hospital. First, I'm going to start with this. Maybe I'll do some breathing exercises, and maybe I'm going to apply what worked for me. Maybe being exposed to music therapy. There are things that are not expensive that people can try, and then escalating to over-the-counter medications. Often, we tell people in the hospital about scheduling their over-the-counter analgesics, non-steroidal anti-inflammatory drugs, acetaminophen, and sometimes it's the first time they've ever heard this. And I think that we often take that for granted, but I think that providing that education and then giving them those resources to say, look, these are going to work better, especially when you're having an acute exacerbation, to take them on a schedule for a very short period of time until your symptoms resolve, I think is something that they can use for a much longer period of time in case their pain becomes chronic. And then, of course, there are more invasive therapies. Dr. Gori mentioned opioids. I think we all agree that they're a powerful class of drugs that's been around for 1,000 years. So I think that they have a role, but they really should be used in case of emergency or in those cases of very severe pain. And then we have procedures. And I think that there are many procedures that really can help many patients with chronic pain. I'm personally, as I mentioned before, I think that we need to have work to do on the advocacy end to make sure that that insurance companies cover them, that patients have adequate networks so they can see a specialist. And I think that there's still more work to do. And we've learned a lot about telehealth, but I think that giving patients access to a specialist who's trained in pain medicine, regardless of where you live, I think is something that we have to keep working towards, because while many of our patients, they'll see their primary care physicians or healthcare professionals for many of their needs. If you live with chronic pain, you're going to need a higher level of care and a higher level of access. So that's something that I think we can all work towards within our U.S. healthcare system.
Yeah, that's a great response, Dr. Mariano. And it really goes kind of a segue. We have a great question from the audience, and it goes along the line of, how would you manage a patient who comes to you with a history of long-term opioid use in the outpatient setting? Dr. Gori, Dr. Mariano, and Dr. Doshi, I'm sure we've seen this at multiple locations in our practice. Personally, it really goes back to understanding why the patient is in pain, because an understanding of the pathophysiology is so critical. Was the initiation of opioid, at least in my practice, when that initiation of opioid was instigated, why was it instigated? And how has the pathology progressed? And I think for me personally, what I do, it really is, it's a detective work where you have to understand why the patient is in pain, so you can come up with the right diagnosis to treat the patient and eventually start tapering off the long-term opioids that the patient's currently being on. From your experience, what have you guys done, and how have you managed these patients when it pertains to they show up to your clinic with long-term opioids?
Well, I think we have to first, as you said, understand the etiology of pain. And I think you said that's exactly right. Secondly, understand whether the opioids are working, because a lot of times they're not. And they've been used as a stopgap because patients don't have any other option. And patients kind of stay on things until doctors tell them that it's not in their best interest. I'd say the last thing is really understanding what the patient's goals are. Because oftentimes you'll find that patients' goals, while their goals are to get their pain better, they want to get their pain better for another reason. And so that second question of, what are you looking forward to doing, or why do you want your pain better? And oftentimes it'll be, I live in Arkansas, so most times it's, I want to go to Walmart. But it can be anything from, I want to play with my grandkids, I want to play golf, or I want to travel. And so then you can create a plan with the patient, with their input, to ensure that they're able to do that thing. And when you phrase it in that goal-oriented kind of pain care, patients often buy in more. And you can have a conversation about whether the opioids should be a part of that goal or not. And sometimes they are, and sometimes they're not. And when you talk about the side effects and the effectiveness of those opioids, then it opens up an entire conversation about how to get that patient from where they are to where they want to be.
That's great. That's truly great. I think we're getting close to like the end of this conversation, and it's almost like we just got started. And I wanted to just open up the mic and just final thoughts. I would love, a one-liner from our panelists here to just give a word of advice for the audience and even patients who may be listening to this conversation. What are some of the simple things that we can take away from this conversation today as it pertains to just caring for patients who are in pain, regardless of the color, shape, form, or just it can go on and on and on. Just a one-liner of things to really think about, and then hopefully we can wrap up the conversation.
I think I would just go back to say that I think one of the things we can do, and we always strive for, and we have a lot of work to do, is just to provide just broad, evidence-based, good pain management that's accessible to patients regardless of where they are. That takes a lot of work at the individual level, up to the national level in terms of legislation and advocacy. But I do think that one way that we can really think about it for ourselves in our own practices is to ask yourself whether the differences in care between patients, in your clinic or on your list, are they warranted or unwarranted? And remember, warranted is good because that's based on patient preference, is patient condition or evidence. Unwarranted is the opposite, and that's what we're trying to avoid.
Well, I would say just everybody, it's so important to remind yourself why it is you're doing this in the first place, right? All of us are here ultimately because we want to help people. And the way that we help people in this context is to first acknowledge our own limitations and to use knowledge to help overcome those limitations as best we can to help people.
Yeah, I think Dr. Doshi really bottom lined it really well when she talked about listening. There's a physician, Nicole Rochester, who gave a TED Talk and came up with this concept of the 90-second encounter, of starting every interaction with a patient with a humanizing conversation and not just jumping right into the medicine or the facts, right? Ask people about what they had for lunch or compliment them on their shoes, and humanize them, because that's going to increase the chances you're going to listen. It's going to increase the chances you're going to have empathy because you're going to see them as a fellow human being. And so at the bottom line, as was said before, remember why we're here, but then also interact with our patients as if they're fellow human beings and not just a medical condition that we're trying to treat.
That's incredible. Thank you so much, Dr. Doshi. Thank you so much, Dr. Gori. Thank you so much, Dr. Mariano. Sincerely, it's been a pleasure conducting and discussing this critical topic with every single one of you. I will turn the mic to Christine, who is going to give us a final thoughts with this webinar.
Thank you to our moderator and our panelists for this great discussion, and thank you to our audience for your participation today. After you exit this session, a feedback survey will pop up in the lobby. We have the recordings from all 3 sessions from today's summit, and we will post those on heart.org/pain management in a few weeks. Please be sure to check out this website for current and future educational opportunities and to join our mailing list. We want to thank you for your participation, and we hope to see you soon at our next event.